Yep. Okay. Sam should be on. Sorry for the delay, guys. There was some technical difficulties. Sam, can you hear us? Sam, you're on mute.
Can you hear me now?
Yep. I just made you the presenter. So,
You see me?
Can't see you just yet.
So I keep turning the camera on and it turns off.
It's okay.
Not that much to look at, but let's see.
Thanks for being patient, everybody. We're working through this, and then we're going to get this started. Dr. Sam Alborz. Some of you may remember from our last continuing education we did in Cuyahoga Falls, Ohio at the COLTENE corporate office. And today we're going to go over a presentation that Sam's put together specifically for the Cleveland Dental Management Group. And there you are. Perfect. All right. The vocals are a little bit messed up there, Sam.
How you doing, Sam?
Sounds a little bit rough there. So they switched his Wi-Fi and his password today, so that's, I know that they're experiencing some challenges there. Still can't hear you. Can't hear you yet. I mean, we hear something, but it doesn't sound good. Sounds like a mouse caught in a trap. Can you turn your camera off? Yeah, again, your voice is not coming through at all.
One it says.
Oh, that's way better. Whatever you just did there, adjust the rabbit ears or whatever you did.
Are we good?
We can hear you perfectly. Yep.
But you can't see me, right?
Not yet, but I think hearing you is one of the most important parts. And if you want to share your presentation,
yes,
I think that would also be part 2 most important. Sam, I'm going to give you a call. Pardon us, guys. Sorry for the technical difficulties here. We're going to get this wrapped up quickly.
Yellow.
Okay, so we can hear you now.
Can you hear me now?
Yep.
Okay, so I think it's the camera has an issue. So I'm just gonna get rid of the video part, okay? Can you see let me see if I can share the screen with you.
Okay, perfect. I'm hanging up.
Okay, we can see your screen. We can see your
hear me?
presentation, and we can hear you.
Can you hear me?
Yes, sir.
Okay. Hello, everybody. Do you want me to start?
Yes, that'd be great. We're recording.
Listen, everybody, thank you so much for putting up with me and the technical difficulties. I apologize. I've been at it doing endo now for 11 hours straight. And that just shows you how much I love endo, right? You know, I briefly talked to your boss, Dr. Rosenthal, and Peter Booker from COLTENE, putting our heads together on how we can help you best. And I'm going to make you an endodontist in less than 1 hour here. I hope you're all ready to go. I'm excited. Look at the title, Effective, Efficient Endodontics. And this is what I want you to do, and do it comfortably. This slide is, I think, everything you need to adhere to when you're looking at doing endo, okay, in preparation, during and after. You must get a fresh PA and a bite wing. I'll go over each one of these, okay? CBCT, if available. Every case in my office gets a CT because I deal with complex cases and I need to see what's going on. Rubber dam isolation. You must use a rubber dam. Please, please, please. Caries control, gingivectomy as needed. This way you determine restorability of the tooth and do a quick buildup. Okay, the point is that I don't want you spending 2 hours on a molar root canal or a premolar, 2 visits. Then it's just really inefficient, and it's like as if you're paying the patient. So you should be able to remove the caries real fast, isolate that area, the distal caries or buccal caries, do a quick buildup with composite or glass ionomer. That way the pulp chamber is sort of isolated now, and you can get that tissue out of the pulp real quick and start looking for canals. You're spending 10, 12 minutes maybe looking for canals. And if in 10, 12 minutes you cannot find canals, with the way I'm helping you, quickly sponge, provisional restoration, take the tooth out of occlusion, 600 ibuprofen, send the patient to an endodontist. This way you can charge out for a pulpotomy, quickly get paid for it, you've secured your buildup, and it's ready to go for next time, and you know the tooth is restorable. Okay? I'm not telling you to refer everything out, but I'm just saying this is a quick way to do something for the patient and send them out the door in case you can't do the case. And this company, COLTENE, has everything you need from diagnosis to dental dam, isolation, access, shaping, cleansing, obturation, and restoration of the tooth. Okay, all full circle all the way around. In my opinion, a good general dentist can do predictable endo. I believe in that. Over 80% of endodontics is being performed by general practitioners in this country every year. Now, we said PA and a bite wing. PA, everybody knows about. You can see the lesion here, the pathology, of course. But why a bite wing? Why do we have to take a bite wing? And I take one as an endodontist every single time. And I'm posing this to you. I know you can't chime in and ask me these questions, but why a bite wing? For many, many reasons. Look at this bite wing right here. Look at the margins of the restoration. That's a well-placed crown. Yes, the bone looks good. These are the key things I'm looking for, but these are some of the things that you should be looking for. The caries extent, right? Is it restorable? PA, I can make a tooth restorable for you with a PA by adjusting the vertical angulation of the beam, but the bite wing is key. It doesn't lie. The height of the pulp chamber, key. This is key. If you have a paper thin, wafer thin roof to furcation, roof to floor of the pulp, do not attempt that case. You're wasting your time and the patient's time and frustration for you and your staff. Those ones, I would say, bow out of those and send it straight to the specialist. The quality of the margin of the restoration, the crown that I'm going through, how good is the crown? Am I going to go through this crown and hypochlorite is going to leak all over the place? I want to know that, and I'll see it on the bite wing. Perio status, etc., etc., etc. Fresh bite wing. Look at this one. Tooth number 15. Is this, can I restore this? Look at the bite wing. I apologize. Look at the bite wing. Quite a bit of bone loss. There's probably a crack on the mesial aspect of this tooth. She does have generalized perio. So the bite wing is key. This diagram, I thought this would help you a lot, just to give you an idea. Okay, from your reference point, from a cusp tip to the roof of the pulp is about 6 millimeters, as you can see right here. Okay, so you probably know in a molar that you can sink the burr by 6 millimeters without hitting the furcation of the pulp. So keep that in mind. Very, very important. The typical height of a pulp chamber is about 2 millimeters, okay? And about another 2 to 3 millimeters of furcation or meat, if you will, in the furcation area. So if I see a practitioner, general or endodontist, that perfed the furcation, I kind of wonder if they were really paying attention. So if you really make these calculations, if you sink the burr on average 6 millimeters into a molar, you should not be going into the furcation. Okay, you should not be going into the furcation. But these are some of the burrs that I use for accessing the tooth. Again, I use a round diamond for most of my cases, 801018. Okay, or diamond, not just in crowns, but even in dentin, I use diamonds because there's less vibration, the patient's less jumpy. If I'm dealing with a full gold crown or amalgam, of course, you all know the 557 transmetal burr, or you can use a regular 557 for your access also if you want. And also on a lot of cases, I'll use a number 2 surgical length round burr to begin my access. And once I've kind of gotten through the roof of the pulp chamber, then I'll put a safe-ended carbide in there. You want to rest it on the pulpal floor. Please don't press with that. It is a non-end cutting, but I wouldn't press with it because you're going to burn the burr. And just go to the line angles. Yes, mesiobuccal, mesiolingual, distobuccal, distolingual, and unroof the pulp chamber, okay? Remember we talked about caries control, unroofing the pulp, and doing a quick restoration on that wall that's been destroyed by the caries so that you can see what's happening inside the pulp chamber and then look for the canals. So here it is. We're just unroofing the pulp, as you can see, with a round burr. And then you can use a safe-ended carbide and put it right here on the furcation floor and gently move it to the line angles. This is what we call an ideal access today. This is what we were taught in dental school. I think this is a little large, folks, because at any given moment, you're only working on one canal. So I need straight line access into one canal at a time. I can't work on all 4 at the same time. So something more towards what you see on the left. And it's very important that after you've made your access, you get rid of this little triangle right here. I'm going to show you what that triangle is. That's, I think, where a lot of people get stuck and they cannot get into the canal. When we talk about using a number 2 round burr, particularly in an anterior tooth, get the long axis of the burr in line with the long axis of the tooth and enter just above the cingulum. I don't recommend going in horizontally and then converting vertical. Start your access vertically so you can end here. Okay, so begin with the end in mind. And before we do any kind of endodontics, these are some of the things we have to think about. And the number 1 thing is rubber dam isolation, okay? As you know, Coltene is well known for the rubber dams, always have been. And these are the clamps that I use. And this is the clamp that I use 90% of the time. The A just means that on the buccal side of these clamps, you will have some serrations or some teeth. It's serrated for better retention. And I use a 2A clamp, which is a premolar clamp, even on molars, because most molars are pretty skinny at the CEJ, and it works really, really well. This is their new rubber dam, which is the Isolate dam right here. Again, you put the rubber dam on the frame, you punch a hole in the middle, put the clamp on there, take the clamp and the rubber dam, the entire ensemble, to the mouth and isolate a single tooth. This is a position paper from the American Association of Endodontists. And if you do a root canal and you do not use a rubber dam, you're going to be in trouble. Okay, this is the standard of care. I highly, highly recommend the use of a dental dam. So this is some of the stuff that I was telling you about. Again, Dr. Rosenthal was about really helping you guys in being able to get comfortable with endo, sort of a step-by-step approach. This is deep caries on 2 molars. Yes, we perform caries control. Gingivectomy, I use a hot instrument and we do a quick gingivectomy, get the gingiva out the way. Quick buildup of the mesial marginal ridges with composite. Here it is right here, and here it is right here. And beautiful endodontics with perfect isolation. I have a great reservoir for my hypochlorite to sit in. I'm not worried about the bleach going down their mouth. And more importantly, I'm not worried about blood, bleeding, or saliva getting inside my teeth. So I'm putting my money where my mouth is, and I'm going to show you case after case after case. This case came to me. I did this a couple of weeks ago. Hey, that's deep caries. I'm not sure if it's restorable. The patient said, I'm not pulling my tooth. So we sat down. And we did caries control, gingivectomy, and here we are building up the distal wall, and there's the end result. This is something that we do every day in our practice. So for you guys to get your feet wet, quick caries control here, isolate this, build up that distal wall, then start looking for canals. Believe me, it will make your life a lot easier, and you know your tooth is restorable. If you're having a tough time and you can't do the buildup, there's something called Cool Dam made by Pulp Dent. This is unfilled resin that you can put around the tooth. We put it around the clamp for perfect isolation. As you can see, this is a crown prep tooth. It was difficult to get good isolation, so we supplemented with Cool Dam. Here it is, another case right there, and so on and so forth. I just did this case last week on a 12-year-old kid under IV sedation, and you know, everybody was going to pull her tooth. They didn't want to pull it because her second molars are not erupting. She has some ultrapassive eruption issues. And, you know, there's a lot of caries, a lot of gingival hyperplasia there. Quick caries control, gingivectomy, cauterize this. I did a quick buildup here with glass ionomer because of the depth of the caries, and did the endo and then built it up with composite. This is step-by-step approach. This is a case I did last week, okay? This is real-time endo. Caries excavated, by the way, that's the mesial aspect of the impacted tooth number 31. I put an epinephrine impregnated cotton pellet in there. As you can see, there's still a little bit of heme in the chamber. That's okay. Etch, prime, bond, rough buildup on the distal. I haven't finished the margins yet. Look, I have a perfect reservoir for my hypochlorite. This is the end product right here. Again, before, after. Okay? This is something, naturally, this is a difficult case, but you guys should be able to do this on more routine cases quite easily. What do I use for composite? For those quick buildups on the mesial marginal ridge or distal marginal ridge, I will use this, which is Everglow Float. It's fantastic. I use tons of it, tons of it. Do a quick distal marginal buildup with that. And the actual buildup itself, I will use Brilliant Everglow, packable composite in these shades. It doesn't matter. Now, if you have a crown or a PFM or a porcelain crown that you went through and you want to seal the access, I recommend using something that has an opacifier in it. So this is opaque bleach, and it's very highly filled resin, and you don't get that show through of the metal on the composite that you do on the occlusal. Okay, this fills it in nicely, and it matches with porcelain very, very well. Again, putting my money where my mouth is, deep caries, excavated. Here it is right here. Quick gingivectomy, buildup of the distal wall, endo performed, 4 canals, as you can see, MB1, MB2, DV palatal, and here we are. Okay, this is bread and butter endo, and what you would do is excavate caries, do the buildup, start looking for canals. If you have a tough time in this, in 10-15 minutes, you tap out. You put a sponge inside the pulp chamber, cover it up with Duotemp, which is a provisional restoration, lighten the occlusion, 600 ibuprofen, send them out the door. By the way, please write down all your questions at the end. I will address them all. Again, another case, very deep caries on this one. And this was under the microscope, caries excavated, previous composite removed, gingivectomy, built up the distal wall. And this is how a case gets delivered to my referring doctors. They're spoiled. This is what they get. Okay, this is the composite that we built up. Again, here again, very deep caries, highly calcified canals. And here we are, 1, 2, 3, 4 palatals over here. Now, in order to find canals, because Dr. Rosenthal was asking about canal location, you need magnification, and more importantly, you need illumination. Just loops with no light, no bueno, not gonna work. Now, naturally, as an endodontist, what do I use? I use a microscope. Everything from caries control to the final restoration is done under the microscope. I use my loops only for numbing the patient up and adjusting occlusion. That's it. Now, this is a difficult case. For example, I recommend you do not attempt. This is a difficult case. Look at the recession of the pulp chamber down here. It's relatively thin, and the mesials are highly calcified. Patients in dire pain, I would not recommend you attempt this because getting into this pulp is going to be very difficult, and you might perf the case, okay? This is a micro CT of a typical molar that's undergone some calcification. What I want to point out to you is that this orifice for these mesiobuccals or these mesial canals used to be over here. With tertiary dentin formation and calcification and pulp stones, the orifice has been projected to the distal, as you can see. So you would essentially, we're going to end up here when we finish our access and removing this triangle ledge of dentin. Okay, this is the ledge that you have to remove. So here it is in real life. This is MB-DB palatal, and this is MB2. And this is that shelf of dentin that you must remove in order to have access to the MB and MB2. What do we use as endodontists? One, we use ultrasonics a lot of times, but more often these days, you'll see endodontists using these burrs right here that are called mount spurs, M-O-U-N-C-E. And this is the website, Dr. Rosenthal. Perhaps this would be a great thing for you to get for the folks in your offices. CJM Engineering is the website. You go on there and you want to get these 34 millimeter #1 long shank round burrs that go in a slow speed. Okay, so you have a case like this. You've excavated caries. Of course, you do a better job than this. And you found the buccal. You're looking for the lingual canal. Where would you trough? Right here, where you see that dot of calcification right there. So you need the magnification and illumination, and you would trough with those mount spurs right there, and you locate the canal, and you have a beautiful case like you see here. Okay, this is a maxillary molar case. They found that, I'm sorry, I apologize. Okay, this is the MB, and you want to trough right here in this line, and this is where you're going to find the MB2. Okay, in this line, this is where you put that burr and you brush it back and forth, rinse dry, brush back and forth, rinse dry, use an endo explorer with some pressure to locate the canal. This is a C-file inside the canal that they've located, and it's that triangle of dentin that we have to get rid of. What's the prevalence of MB2? People always ask me in the maxillary molar. You're looking at 70 to 90%. 70 to 90% of maxillary first and second molars have an MB2, and you have to look for it. Again, I said a general dentist equals predictable endodontics. I want you guys to do these cases, but I want you to do it right. I don't want you to do it for an endodontist to come back and fix what you have done. Retreating cases is not good. It's not good at all. Again, here it is. This is the MB. This is the distal buccal. There's the palatal. Look, they've put some IRM here just to isolate the tooth so no bleeding from the gingiva comes in. And you're going to get that mount spur and and brush back and forth here. And we're getting closer and closer. Brush back and forth here, and boom, you fall into the MB2. You put a C file in and work it, and this is MB1 and MB2 after they've been shaped. Again, this is the burr that I recommend. I use it routinely on a daily basis. Bread and butter endo, bread and butter endo. This is a case that failed with a large lesion, mainly and primarily because of the missed MB2. And once you access the case, they found MB-DB palatal. Right there's the MB2. But folks, without illumination and magnification, it is impossible to find it. Now, what do you do if you can't finish a case? You know, you've excavated the caries, you did the quick buildup, you've located the canals, you've shaped it, you've cleansed it, the sucker is bleeding, especially in a young kid. Hey, you put calcium hydroxide in there, quickly dry it, throw calcium in there. If it's still bleeding on you, put calcium in there and push it to length with your hand file. Calcium hydroxide is a hemostatic agent. It will help prevent drainage and stop bleeding because it necroses tissue. And you sponge, duo temp, take tooth out of occlusion, 600 ibuprofen, send it out the door and bring it back to real point. Don't spend 30, 40, 50 minutes wrestling with a bleeding canal or a draining canal because of purulent exudate. Okay, when I see a lesion of this size, the tissue pressure down here is tremendous. And I have a good feeling, and I prepared the patient, hey, this is going to be two-step endo probably because this is going to continue to drain, okay? Don't be shy about that and allot that much time. Always take a radiograph after you place the calcium hydroxide for many, many reasons that we can discuss next time. What do I use? UltraCal by Ultradent, and it's calcium hydroxide, water paste. I use these capillary tips. Specifically, I use this one right here, and you put a bend on it a few millimeters short of your working length, and gently, without engaging the canal, you squeeze calcium and push it down with hand files. I know I'm going really fast because I'm trying to cover everything for you guys. Please write down all your questions and I'll be happy to answer them. We talk about shaping of the canal. Now, remember, we've got the caries excavated. We did a quick buildup. We've located the canals. Now we're ready to shape them, right? Use an apex locator. Please always use an apex locator. With an apex locator, we're measuring this right here, which is the minor constrictor. Okay, that's what we're measuring. It is 99.9% accurate in locating your apex. Now, what I recommend you use when the file jumps up and down with the apex locator is some kind of insulation material. Filese is what we used to use. There's better stuff on the market. You coat your file and you stick it in the canal. Look, I still have some tissue here, but this kind of stuff, Filese, this is what I use. MD Kel Cream, Metadent is the company, and there's many of them. Okay, it insulates the file. Think of a wire, electric wire, that is coated, and the wire is in the middle, and it gives better signaling with an apex locator. And this is the case completed. Cleaning and shaping, I don't like that term. I prefer shaping and cleaning, because remember, the instruments shape and the irrigants clean, okay? So first we have to shape the canal, like you see here in this wonderful study. This is a maxillary molar, mesiobuccal, distal buccal, mesiobuccal, MB2, and palatal. The green areas are the areas that the files did not touch. So we are relying on chemical disinfection of these areas, okay? So now, before we jump into rotary, please, we must master hand filing. And most of these courses, when I go around and I talk to different practitioners, I find that they are deficient in their techniques in simple hand filing. First, determine the size of your canal, small, medium, large. Are we dealing with a lower lateral incisor with a calcified canal, or are we dealing with a maxillary central with a huge canal? And then always start with a 10 file, watch winding, think of a Swiss watch, watch winding to advance the file, and then pull circumferentially on the walls to file and create space within the canal. I always hand file to a 15, even as an endodontist. I'm doing this 20 years. And then I begin with an orifice opener. And I've lubricated the canal and I get a working length. So caries control, quick buildup on the distal. The pulp has been removed within the pulp chamber, a pulpotomy, if you will. I've located the canals. I do a quick orifice opener on all the canals, get my 10 file, and start to go to length and get a working length on each of my canals. Now I work those to a 15 hand file, and I always pre-bend my files, pre-bend the files, because no canal is straight. All my files look like this guy or this guy. None of them look like this unless I take them out the box. One of the pearls I like to pass on to folks is I never grab a hand file by my fingers. It is difficult and cumbersome to place it in the canal, so I use cotton forceps. This is one of my assistants taking this for me, just to show you guys. And this is how I grab it, okay? Pre-bent file held with cotton forceps, and you take it to the canal orifice, drop it in, then you can use your fingers. Always flood the chamber with sodium hypochlorite throughout your work. There is one issue that I would like to touch on, and that is glide path. Glide path, I'm sure you've heard this, is a very important concept. And simply what it means is an unimpeded path from the orifice to your working length. It's an unimpeded path from the orifice to your working length. So once you grab your and obtain your working length, you put the file inside the canal and you work it circumferentially, 10 through 15. Once I'm done with my 15 file, I'll lift it up out the canal, let's say 5 millimeters, and press with my finger. And that file should easily glide back down and stop at my working length. That means I have a glide path all the way down to my working length, okay? Another concept that I think is very important is maintaining patency. A patency, what does that mean? It means that simply a 10 or a 15 hand file must go 1 millimeter past the apex. If it doesn't go, you have either ledged or you've created so much dentinal debris that you have blocked yourself out. So you must maintain and achieve patency throughout your instrumentation. Some of the tips that I can share with you is use light pressure when you're using rotary files, okay? Always go to a 15 and make sure you have patency on 15 hand file before you begin rotary. You're only in the canal one pass, 1, 2, 3 out, 1, 2, 3 out. Okay, no more than that. Every time when we break an instrument is when we stay inside the canal too long. Irrigate after each rotary file. Check for patency. Take a 10 and go past the working length, 1 millimeter. Clean the rotary. Clean the rotary. Get the debris off of there. We use sponges. We stab the file inside a sponge because if you have debris on there, you increase friction, and the friction can lead to separation of files. Okay? Always, always flood the chamber. Always flood the chamber. Now, just to go into basic concepts with rotary instrumentation, in the COLTENE files and many other systems, we talk about this concept of opening the orifice with the orifice opener, using a glide path file that is close to your hand file, right, to make sure we can go from the orifice all the way down to the working length. And then this is your bread and butter. This is the shaper. This is what's going to shape your canal all the way to the working length. And then finishers. Sometimes you have canals that are very wide at the apex, and you cannot just finish with a size 20. This is size 20 at the apex. That's too small. And then the finishing file, which the EDM system offers you, fantastic options. Look, again, in cartoon schematic, the orifice opener is up here at the top of the orifice. Then the glide path goes all the way to working length. Your shaper goes all the way to working length. And the finishers, as needed, go all the way to working length. This is a slide you may want to take a picture of. This, I think, is going to be bread and butter endo for you. Remember, we now have established working length. We have hand file to a 15 hand file. Next step, we've already done orifice opener. We will go, this guy is what I recommend, the 2005 or the 2004. That's your shaper. Most of the time, I would recommend you begin with this. And peck, 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 take it out, rinse, irrigate, clean the file, peck, peck, peck. Again, back and forth until you reach working length, okay? Most of the time for you guys, this after the orifice opener and a 15 hand file, this will go to the apex. If it doesn't, please grab this guy, which is a glide path file, and go all the way to working length and then go back to this. I'm saving you a step. So from orifice opener straight to 20. It goes against that OGSF thing that I was just telling you about, which is the glide path file. You can always use a glide path file if you want to be safe. But I think in most cases, you can bypass it and go to this. And that's for small canals. For example, like maxillary lateral incisors, like mediobuccal root of molars. Those are smaller canals. And you can finish with this and you're done. If I would recommend you gauge the apex. So let's say you did orifice opener and you did this guy and you did this guy. So that means at the apex, you have a size 20. I recommend you grab a 25 hand file and see if you can put it to length. If you put it easily to length and it's kind of loose down there, that means that apex is larger than 20 to begin with. So you can't really finish with a 20. This is where the doctor has to come in, and you have to really put your doctor hat on, and it's not like a cookbook kind of thing. If you put a 35 hand file down there and it's really loose, guess what? That apex is larger than you think. And that's when you would jump over to these finishing files. Let's just say I put a 35 in there and 30 was loose, 35 is getting snug, and I would finish with this guy, 4004. Just enlarging the apex just a little bit more so you can do beautiful endo, not mediocre endo. Okay? And another thing I'd like to point out here, let's say you're doing a maxillary central incisor or a larger canal, then you can use orifice opener and go straight to this guy, which is the 25 file for most canals, and it should go down to length, like palatal of maxillary molars and maxillary centrals and so on and so forth, okay? And then you can finish with whatever finisher you like. A lot of centrals, maxillary centrals actually finish to a 6002 because the apex is large. Once again, watch this. I've already got the working length, orifice opener, glide path, if you will, to length, and shaper to length. Gauge the apex and finish with one of these guys. If it's really, really tight with a 2025, you can finish with this, the mesiobuccal root, distobuccal root of maxillary molars, okay? Watch this again. Orifice opener to resistance, here it is. Obtain working length, yes. Hand file to a 15, take a picture of the slide. You take the glide path file, here's your OGSF. Glide path file to working length, the 2005, which is this one right here, to length. And if it's a small canal, you finish with this. If it's a larger canal, remember you can bypass that yellow one and go straight to the red one and take that to length, gauge the apex with hand files, and finish with the finishing files. So moving forward, let's show you guys some money shots. Yeah, this is it. Boom. Okay, this is finished to a 40. This is a 60. Next one, very complicated tooth. I didn't expect you guys to handle this. This is finished at 2005. Orifice opener, glide path, 2005 to length. Okay. This is same thing. Here it is again. This one, these ones were actually wider, so I took the 25 all the way to length and the 4004 on the distals. Caries control, mesial wall built up with little composites. This is orifice opener, shaper, which is the 2005, finished with 4004 on the mesials and 5003 on the distals because the distals were wide. This is that case that I showed you. There it is, MB12 merged together. This is orifice opener, 2004, 4004. These were large canals. You cannot finish this to a 2004. This apex, look at it. That's like a 25-30 apex. You can't finish it with a 20. So I finished the mesials to 4004. So it's orifice opener, 2005, which is the yellow guy, finished with the black one, which is the 4004. And the distals were really wide because of resorption and so on and so forth. So that's 6002 on the distals. Here it is again. These are the shaping files, the finishers, I'm sorry, that I mentioned to you because we had wide open apices here. The mesials are finished to 4004, the distals to 6002. This is a younger kid. This is a central incisor, big wide canal. I just used a 60 and went straight up, peck, 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 in a pecking motion, okay? That's a 60 at the apex, and look how slender it is up here. So we maintained a lot of the dentin, right? This is a complicated case. It's entomolaris. It has an extra root here on the mesiolingual aspect of the tooth. Very, very calcified. Orifice opener, glide path file, 2005 on every one except that distal one was wider, so that's a 4004. Finish. Remember, the green areas are the areas that the files did not touch, so we rely on chemical disinfection of those areas, right? Irrigation, irrigation, irrigation. In regards to irrigation, I know I'm going really fast, guys, but I don't have much time. Never use an open-ended needle. Never, ever, ever, ever. Only a closed-ended side port needle. 30 gauge, 30 gauge. Once I obtain my working length, I put the bend on my irrigation needle, not before. And I put it about 2 millimeters short of working length. It's always loose within the canal, and I'm moving my hand up and down, up and down. You cannot irrigate 6 millimeters short of working length because it will not reach the apical portion of the canal. Now, you also don't want to stick that needle into the canal and engage it and press because you can have a hypochlorite accident like this young lady here. My hand is always moving up and down within the canal. Now we talk about obturation. We remove the caries. We did the gingivectomy. We did the quick buildup. We located the canals. We have shaped them. We've irrigated them. And we talk about obturation of canals. Well, most of the problems with obturation, if you're having a problem fitting a gutta-percha cone, it's related to your shaping. You have to go back to your shaping and take a couple steps back, rehand file, refile, and it will fit. Okay? We're talking about three-dimensional obturation of the canal. Please don't use thermofill and carrier-based stuff. I just retreated a bunch of thermofill, and it really is horrible. Thermofill has so much gutta-percha that excess comes out of the carrier, fills the chamber. You cannot do a proper buildup. You have leakage of bacteria because your buildup was inadequate. Plus, your boss is going to like this. Thermofill is expensive. Expensive. You know, $10 a carrier, and you want to put it in a 4-canal molar. That's $40, $50 in obturation material. No way. Mine costs 30 cents. Gutter flow is a great happy medium. It's similar to what I do, and it's a little bit easier for you guys. The tug back is tug back, right? Make sure you fit your cone. You want tug back right here. Take a radiograph, obtain your working length film. Tug back, not up here, but in the apical 3 millimeters, okay? That's false tug back, and we want true tug back. So what you do is the gutter flow is a mixture of gutta-percha and sealer. You dispense about 1/2 of a pea size on a mixing pad or a glass slab, coat your master cone, seat it. I would take it out, put a little bit more on the tip of it, and slowly seat it. And then sear it off at the orifice, press with a plugger, and you are done. Okay, so if you finished, for example, to a 4004 EDM, you can either grab a 4004 cone and see if it'll fit. And if you're having a tough time with that, grab a 3504 cone, one size smaller, and maybe snip the apical aspect of that gutta percha cone by a 0.5 millimeter and seed it, take a radiograph. I think you'll be happy. Okay? And then, so I've finished my case. Now you get a cotton pellet soaked with alcohol and you clean the chamber. And after that, you must use a total etch system because hypochlorite oxidizes dentin and you cannot bond to that dentin that is too oxidized. And phosphoric acid reduces the surface tension and you get a better bond angle, okay? Let's just say you can't finish it and you have to provisionalize. This is the best stuff. Every lecture I give, everywhere I go, the dental reps come to me and they say, oh my God, since you lectured, I have sold so much duo-temp, it's not even funny. This is really, really good stuff, guys. It handles just like Cabot. It has no eugenol, okay? And you can cure it. So it goes in like Cabot, manipulate it to the shape you want, use your wet cotton Q-tip and wipe off the excess, use an Explorer, wipe off the excess, cure it with a light, and it's hard as a rock. And it has no eugenol, will not affect your bond. If you have to do a buildup, again, this is what I use, flowable, brilliant, flowable, Everglow. And then I do my buildup with these guys. And if I have a crown, I will use this guy because it has an opaque filler in it, and I don't see the show through of the metal. The bond that I use is this one coat. I've been using this for years. It's excellent, excellent. My referring docs love it when I do the buildups for them. I do a lot of, what do you call it, post placements, and I use Paracore and Parabond, and these are for teeth that are missing cuts or cervical fractures of maxillary or mandibular anterior teeth. And I use a lot of fiber posts and Fiberlux posts. The smallest one I can get in the canal. Do not take a post drill burr and destroy the canal that you were so conservative in shaping and open it up just to fit a post. Get the smallest post you can get to fit in there. Dual cure bond, dual cure composite, which is Paracore, seed it, do your build up. I cure it with this light, the Spec 3 light. I've had these lights for years and they are made of aluminum. They are not flimsy and they do not break. This I'm just sharing with you. Endo works, okay? Endo works. I've been doing endodontics for 20 years and it has really rewarded me well. I paid off my student loans, you know, paid off most of my house, paid off my cars. I traveled the globe. Endodontics has been really good to me, even with, you know, this constant talk about implants. Despite all of those things, my schedule is packed. There are plenty of people that would like to retain their natural tooth. Believe me, every dentist out there would rather try root canal on their tooth rather than seeking extraction. And it works. And this is a cracked second molar that came to me. And I told the patient, hey, this may or may not work. She said, I don't care. Please do it. And this is a 3-month recall. Look, this is CT. Okay, we went from here to here in 3 months. Look, from here to here. So it works. Please do it effectively, do it efficiently. And I'm going to come up there to Ohio and sit in person with each and every one of you. And we will do this hands-on, and I will, you know, get you very comfortable in the cases that you should be doing, and maybe deter you from a few cases that you should not be doing. Now, with that being said, folks, I hope I'm on time. Please fire away with questions. I'm ready to go.
Okay, Sam, great job. Any questions from anybody that?
And this is my email. If you guys want to email me with questions at any time later on, that's fine. If you want to ask me questions now, fire away. I'm ready.
And if questions come up throughout, you can use the chat feature in Teams to ask any of the questions that you might have. And yeah, Sam, that was great, elaborate, fast, and showed some excellent
Hold
cases
on one
there.
second,
Thank you.
Dr. Booker, 1 second. There's plenty of practitioners here that I see. There has got to be questions. I am not going to hang up until somebody asks me a question. If you guys
There's
want
one.
to type it. Okay, we got Frank here. Let's see. What are your sequences to opening up the MB2 canal? I've noticed more MB2 canals, but the ones I've noticed did not go to working length or was not able to even. You know what? Excellent question, Dr. Frank. Thank you so much for asking that, because I bet you everybody here has that question. Yeah, listen, the question you're asking is legit. It is the most difficult part of doing a maxillary molar. One, locating it. So if you're locating it, you're ahead of many people, okay? That means you're looking for it. My sequence is the same as the others, my friend, but you have to start with C files, which are stiffer, and you're starting with probably a 6 or an 8, and you have to be really patient, and you just put it into the orifice and just work it gradually, let's say halfway, and that's fine. Take the hand file out, use the orifice opener just a little bit, and then flood the chamber with the hypochlorite, put the file in with the cotton forceps, the 6 or the 8, and gently watch winding advance. You already know your working length, because the working length of the MB to be the same as the MB1, and just go to that MB1 length. Do your best. 6, 6, 6. You got to work that 6. Then you go to 8. You got to work that 8 to length. Then you go work that length to 10 to length. This is C files. And then you begin a little bit more orifice opener, and then you go 10 to 15, and then the same sequence, right? Orifice opener, glide path file, shaper, and you're done, because the MB2 is tight. Okay, I hope I answered that question. I have another question here by Amish. Thank you, Amish. Do you use EDTA? I did not go through my irrigation protocol. I apologize. In 50 minutes, I can't make you an endodontist, but I will come to Ohio and go through everything in detail. But yes, I do use EDTA. So I use hypochlorite throughout the entire shaping process, okay? I fit my master cones with hypochlorite still flooding inside the canal and in the chamber. I take my radiographs. I am happy with that. I take those master cones, I lay them on an alcohol gauze, I spray more hypochlorite in there. Then I will aspirate and remove all the hypochlorite, dry the canals, then introduce EDTA for 1 minute. And you got to use your master cones to pump that EDTA all the way down into the canals. Leave the EDTA in there for 1 minute. 1 minute. Dry, obturate. I hope I answered your question there. Next question by Dr. Dennis. Do you recommend using RC Prep? I've heard different opinions on using it. I've heard some docs just use sodium hypochlorite as lubricant. Yeah. I have no problem with you using something like RC Prep or Fialese or that kind of stuff. The MD Kel cream that I showed you, the MD Kel cream is far better than these other guys, because it's very lubricating and very soft and not clumpy. And it's inexpensive. Dr. Rosenthal, as a business owner, appreciate that. You can readily have that available in your offices. I think because the other ones are brand names. This is a Korean company. It's very good. I've been using it for 10 years. And you can use it throughout your hand filing if you wish. But honestly, if you really think about it, once you have your work, flood the chamber with hypochlorite and let the bleach work for you as you are working on the tooth shaping, okay? The longer we have hypochlorite inside the canal, the more disinfection, the more tissue dissolution is occurring. So that's my suggestion there. But I have no problem for you using it as a lubricant just through hand filing. But once that working length has been obtained, please switch to hypochlorite. And also, you'll find that there'll be a reaction with the hypochlorite and the RC Prep or Fialese, because they have hydrogen peroxide in them, and the reaction between hypochlorite leads to effervescence or bubbles, and a lot of debris will come out of the canal. So it's a great reaction between the RC Prep and the hypochlorite in removing debris from the canal. Next question, Dr. Bria. The hypochlorite, you recommend diluting it? Excellent question, Dr. Bria. Never dilute the hypochlorite. Never dilute the hypochlorite. I've never done it. Let me tell you why. If you're worried about a sodium hypochlorite accident, even if it's a 1% or a 0.5%, they're going to have that reaction, because a hypochlorite accident is not necessarily the doctor making a mistake, but sometimes it is because you push too hard and engage the needle. But everything according to plan, it is that patient that has a hypersensitivity to hypochlorite that was undiagnosed. Basically, they never come in contact with hypochlorite and they're highly allergic to it, and that's what that is. So by diluting it, you are not preventing a hypochlorite accident. You're just shooting yourself in the foot and not achieving chemical disinfection of the canal as efficiently, as effectively as I would using full strength. So please, no dilution of hypochlorite. I got another question here by Dr. Frank. What's the amount of time recommended for hypochlorite to sit in the chamber and canals? Excellent question. Very, very good. That is subject to debate, okay? Our previous studies were 1 hour, but listen, I've got patients that are difficult to manage, even under sedation. They're gagging, they're moving, they're jumping around, and we have a tough time. And sometimes we have to rush through these cases. And listen, they heal. They heal. If you do everything correctly, they heal. So am I in there an hour? No. But I use other techniques to adjunct my hypochlorite. And once I come up to Ohio, I can show you guys that. And Coltene has this device, and it's not expensive to have in each office. And that's acoustic streaming and activation of the disinfectants that we use. And that speeds up the disinfection. And that way we don't have to be in the canal as long. But for your cases right now, I mean, I think the hypochlorite needs to be inside the canal at least 30 minutes, 30 to 40 minutes. I would not do it any less than that. And the next question by Jeff, Dr. Jeff, my biggest struggle with molars is just angling the files to go into the canals. I want them to go, especially MB2 on the upper molars. Any tips? Excellent question. First of all, this is the most difficult part of what we have to do, yeah? Especially in the second molar, limited space. The tooth is buccally inclined. The patient has limited opening. Mrs. Johnson weighs 100 pounds. You know, she has TMJ. Yeah, having straight line access, you can establish that with your Endo Explorer. Your Endo Explorer should go into the canal from the access unimpeded. Once you have that, we have straight line access. Remove that dentin triangle or that shelf of dentin that I showed you. Make sure you have that out of the way. Open the orifice. Now grab the hand file with your cotton pliers and do your hand filing, right? Believe me, by putting the hand file with the cotton pliers inside the canal, you are teaching your hand and brain memory for that canal. So when you grab the rotary, you will go to that same angulation. With the EDMs, because you can bend them, if you don't have enough space, pre-bend the file, place it into the orifice, then rotate the file. And that will help you get into the area that you're having difficulty getting into. But what you're bringing up here is one of the most difficult parts of the treatment. And that's something that even me as an endodontist, I struggle with that sometimes. You know, I'm getting your hardest case, yeah? I'm getting a third molar that's hooked up to a 6-unit bridge on a 91-year-old lady that has a gag response. So it's a difficult thing. I would practice on some plastic teeth. There's these 3D true teeth that you can buy, and the rotary just a couple times tabletop in helping you teach your wrist how to get the file into the orifice. Again, pre-bend the file a little bit so you have more space, interocclusal space, put it into the orifice, then rotate. And I think if you have a good glide path with your hand file, that rotary will follow that path. I've got another one here by, this is a very famous dentist. You might know this guy, Dr. Jeff Rosenthal. Says some of our docs fear endo, and that's the purpose of this course. Any suggestions on how to get them engaged and where to start? Anteriors, then bicuspids, then molars, or start with a younger aged patient? Which way may be the best to help them overcome these fears? Okay, you know, anteriors are sometimes hard. They really are. Staying on track, you know, thin little roots, so on and so forth. I think premolars are good. I think some molars are good. Young patients, certainly canal location is easier, right? But they have nice big pulps. Sometimes they're hot teeth because they're not necrotic, they're vital. So local anesthesia is very important. I would definitely do blocks, definitely do infiltration. If I'm doing a mandibular molar, for example, I give 2 mandibular blocks, 2 lidos with epi, and I infiltrate with articaine. Again, I'm doing number 19, right? I give 2 blocks, infiltrate with articaine, full carp, And then I wait 10, 15 minutes and come back and do intraligamental. So I have profound anesthesia, because if that kid feels something, and I would definitely give them nitrous, if that kid feels something, the kid is going to freak. And if the kid freaks, the doc freaks, and it's game over. So if they're comfortable and they have faith in you, they will allow you to sit down and practice, which is the practice of dentistry. And then you do all these things that I told you: caries control, build up the wall, isolate that pulp, remove the pulp chamber, find orifices like we talked about, obtain working length, hand file, rotary file, irrigate, 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 and do your build up right. This is a good confidence builder. But definitely, if you follow these steps that I told you about, there'll be less stress, less angst. Step by step, remove caries first after profound anesthesia. Do a quick buildup of that wall. You guys are restorative dentists. It'll take you 2 minutes. Okay? Now you can see what the heck is happening inside this pulp chamber. Was that bleeding coming from the tissue, or was that bleeding coming from the pulp? At least let's deal with one component at a time, just the pulpal tissue. And you can really practice and focus without stressing out. The last thing you want is a drop of hypochlorite going past the caries wall, past the rubber dam, down their throat, burns their throat, game over. Everybody go home. You'll never do endo again. Stick to these basic concepts that I mentioned to you. If there's any of my slides that you guys want, I can send a few of them. I can email them to Dr. Rosenthal, and he can distribute. If you have further questions, email me direct. I'd be happy to help. Anything I can do, I'm here to help you. But pick your cases well. Pick your patients. Make sure it's not a super anxious patient, and go for it. Again, on the anteriors, remember, line up that burr, number 2 round burr, vertically in the long axis of the tooth, just above the cingulum, and enter the tooth that way. Use a brand new burr, please, when you're beginning endo, because it's, you're going through enamel and dentin, and you don't want to be burning the dent in there. And go for it. Bicuspids, certainly great teeth to do also. I think they're the mini molar, if you will. Maxillary teeth will be easier to anesthetize than mandibular, as you all know. I think you got to go for it. And I think if you stick with the steps that I mentioned to you, it's rewarding. I don't think, as Dr. Rosenthal was telling me, and I agree, in all of your procedures, I don't know of another procedure that's more profitable and lucrative than endo build-up crown for the amount of time spent. If you're doing restorative MOD, MODFL all day long, I mean, you have to do a lot of MODFLs, and you have to go through the same anesthesia and all of that with the patient for very little reward, versus endo, I think, will be much more rewarding from a financial standpoint. And listen, it's served me well, and I've been able to do it. And if I can do it, you guys can do it. And again, I'll come up to Ohio and teach you guys in person how to do it. And through what we talked about here didactically, and me reiterating that over there, and sitting down with you manually with your hands and showing you what to do, you'll get comfortable with it. But please, please excavate caries, do a quick gingivectomy with some whatever you may have, and do a quick buildup of that wall. Then you're only dealing with endo, not endo and caries and tissue and gagging and all of that. I hope that helps, Dr. Rosenthal. Do you have anything else to add to that?
No, I think that's a fabulous suggestion, Sam. I mean, I don't know that I'd ever heard of anybody saying remove the K and then build up the mesial or just a wall to isolate it ever before. And I think that's a fantastic suggestion. The doctors use EFTAs as well, so that's sometimes a way they can break after they get it opened up, to let the sodium hypochlorite sit in there, and why an EFTA builds up the mesial wall, or they do it themselves, whichever way seems to be the the easiest based on the patient. That's a great suggestion. Your presentation is always amazing. That's why I appreciated you taking the time to do this.
Sure thing, of course, pleasure. Anytime.
And
Anytime.
as well as Pete and Carolyn and Brian and everybody at COLTENE for putting this together. We always appreciate the the relationship and everything. I think that pretty much concludes part 1. I think we wanted to discuss a little bit for the last 2 parts, were just the one section that I had here. I think everybody understands endo. I mean, it is one of the most profitable procedures that we do in all of dentistry. And it's extremely rewarding because you take a lot of people out of pain, which is really great. So I think we should continue to do that. I'm looking at myself on the screen and my camera's not working great, but that's okay. You know, I have had the experience of some local endodontists, you know, sort of making a few comments about general dentists doing root canals. Do what you're comfortable with and refer when you're comfortable, but push yourself to get better and improve every day is probably the only thing I can say to you. It's a wonderful and a very long career in dentistry. And the more you do, the more your patients will appreciate not having to build a relationship with someone else that is somewhat of a one-hit wonder. You know, people don't love to come to the dentist anyway. And if we have the best chance to build a relationship with them, we can. But I also appreciated what Sam said about, you know, you've got to know your limits of the time that you put into a procedure, and then you stop and you build out for the pulpotomy, you know, temporize it and go. I don't think that's something that we typically do in our offices. I know Sarah's on the Zoom call, so she can spread the message as well as the other doctors to find out what that code is, and we can put it into our, you know, fee schedule and use it routinely. As long as it's presented to the patient, the pros and cons and the reasons why you're doing it, because the communication is key when you refer somebody to another provider. Other than that, I mean, I just had those few comments, and I think that Dr. Panja, who's in Portage, for those of you that don't know, and Dr. Lamb, who's in Locust, they had a couple of comments prepared, things to talk about, because they've done a ton of endo as general dentists, and it's been very successful. So I think their comments would be really nice to hear as well. Thanks, guys, for taking the time.
I think
Alright,
that, yeah, go ahead.
Sorry. Go ahead. Can you guys hear
I
me?
just wanted to let you guys know, to the dentists that are listening, over 80% of endodontics is performed by general practitioners in this country. Okay, we have 22 million approximately root canals done annually in this country, 80% of which are performed by general practitioners. There are not enough endodontists to do all the endo. There's no way that I could serve my community by saying, hey, leave all the endo to me. But our only argument or point, if you will, as endodontists is, listen, if you're going to do it just as good as me. Don't do it and miss canals or go halfway and then put a restoration on it. Now the patient's swollen. 6 months later, it comes to me and you've ledged it or perfed it or something like that. There's really no reason to do that. You have all the tools at your disposal. And if you pick your cases carefully, you can do very good predictable endo, like I told you. Leakage is the main thing. If, again, by doing that quick pulpotomy and then restoring that area, and you get a good seal on it, on that wall, if you will, and on the occlusal aspect, odds are your endo is going to be just fine.
Awesome. Thank you, Sam. So Sam was perfect for part one. Dr. Rosenthal, thank you for adding your comments for part two. Just getting it, doing it, the billing for that, the importance of it, and just keeping endo in-house. And then part three, I think you said we're going to hear from 2 clinicians. Is that right? I think, Dr. Amish, you're going to go first.
Yeah, that's cool. I think basically, I think Sarah and Dr. Rosenthal asked us to kind of just talk about our experiences and why we're doing it and why we started doing molar endo. I've been doing this for 20 years, I guess. It's almost 22 years, maybe. When I first got out of dental school, I wouldn't touch a molar at all, even after residency and everything like that. And then it just, just started doing, like I said, it just did the anteriors and premolars. And for those of you who don't know, I worked at Portage 20 years ago and then left and got my own practice and then came back. So towards the end of my first go around at Portage, I I was working on a maxillary premolar and it ended up having 4 canals. And then I thought to myself, why am I so scared of working on a molar when I just did a maxillary premolar that had 4 canals in it? So that just told me that just to give it a try. And then same thing with Dr. Sam, that just kind of, you got to pick your cases and just go slow. The one thing that I work with, a couple dentists and porters, and then when we talk about it, we always talk about the same thing over it. If you do the same thing over and over again and you repeat your process, you can get more predictable, and then you can have built-in times and points where you can take breaks and things like that and get stuff taken care of. When I work, I'll go in, I'll numb up a patient, and that gives me time to go. Usually if I have a couple patients in the chair, I'll numb up a restorative patient, numb up the endo patient, go prep the restorative patient, gives my after a chance to fill. Well, then I'll go work on the endo and look for the canals. I like taking working length films with files, so I do that too. While they're taking that film, then I can go see another patient and I come back and I take breaks. But if you ask any of the assistants that work with me, I do my endos the same way over and over again every single time. It's the same step, to the point where sometimes the assistants say they get bored because it's the same thing over and over again, and there's no change in step or procedure, so they kind of get a little bit bored. But for me, it works because it's predictable and I know what the next thing I do, and you can concentrate on doing the simple things. The simple stuff is taken care of, and the hard stuff you're worried about looking for files and taking care of, shaping and cleaning and disinfecting and everything like that. And it allows you to just kind of do the same thing over and over again and not worry about trying to change stuff over and over in the middle of your procedure and things like that. Like sometimes you have to go back with the changes happen. Everything is not completely 100%, but the more you do the same thing over and over again, you can get more efficient in doing things. And sometimes if you slow down and do the same steps over and over, you actually end up going and doing things faster. So, that's basically what I would kind of have to say about that,
Awesome. Practice makes perfect.
Basically, practice makes perfect, and like take your time, but you'll get faster by taking your time. I think is the best way to look at it.
Yeah.
Go slow to go fast.
Excellent.
Let me also interject here on your comments, Dr. Panya, that if we need support, COLTENE is there for us at any time. Carolyn comes around to the office. She'll sit behind you and sort of go through the materials. They know what we have in our office that we use. And all we have to do is arrange to have it done. So if anybody's interested in doing a procedure that they're not comfortable with, I can certainly help them by being there myself. And then Carolyn also can be there to help with the COLTENE systems that they use from their company. And I think Dr. Lamb's up.
Hello, can you hear me?
Yes.
Hello, how's it going? My name's Dennis. I've been with Dr. Rosenthal for 4 years now. And when I first started, I was scared of endo too. So I worked in private practice for 2 years before that, and I didn't do too much endo. I did mainly like some premolars and anteriors, but referred most of it out. But a big part of how I got better was just case selection is a big part of it. So I picked easy, like teeth that look easier, big canals, big pulp chamber, patients that are easy to work on, patients that are not too nervous, they can open wide. And like Dr. Panya said, it's just a lot of practice. You got to pick good cases to practice on at first. I wouldn't pick a second molar as your first molar. I'd pick like a number 30, younger patient, someone that's not super hard to work on. Yeah, I think everybody, if I can do it, everybody can do molars. So it's just a lot of practice. When I first started doing molars, it took me probably at least 90 minutes to finish a molar, maybe more. But as I got better at them, it takes me maybe 45 minutes to an hour to finish a molar now. So it's just repetition. So um, yeah, does anybody have questions or anything?
What
No?
was your biggest fear when you were attempting to do any molars?
I think the hardest part of any root canal is the access for me. So at first, I was always afraid of perfing the tooth, and my um, strategy to prevent that is before I access the tooth, I kind of like look at the outside of the tooth first, and I've kind of visualized where the root would be inside the gum tissue, and I try to angle my burr with the long axis of the tooth that I can kind of imagine, and then I access it with that same angle, and I think that helps a lot. So for me, it's access and finding other canals. But
Okay.
with practice, I got a lot better at doing that. So
Okay. And then, I mean, as far as case selection goes, I think that's a great point. And then just probably explaining to the patient just the steps that you're doing and making
right,
sure that,
and
yeah.
yeah, so a lot of times if I'm working on a nervous patient, I just talk them through it, and I'm like, hey, this is what we're doing. It has a fancy name, so a lot of patients are always going in with the mindset, oh, it's a root canal. I've heard they hurt a lot, and that kind of mindset is setting themselves up for failure already because they're already scared going into it. But then I just talk them through, like, hey, it's not. I'm gonna numb you up for it. It might be a little pain, but the whole procedure should be pretty painless. So
And
if
that's
you
it.
talk to them about it, yeah, they feel better, and then it's easier on you and them.
Yeah. And that's so important, right? I mean, they're nervous. I mean, they've only heard horror stories about root canal therapy, and it's something that, if you're open and honest with them and say, hey, we're going to save your tooth and here's what we're going to do. We're going to try and do this today. And um, have you ever had cases where you opened up the access and either had trouble finding a canal or just felt like, okay, you know what, this is a little bit more complicated, and just
Yeah,
talking to the patient through that, but just
yeah,
opening them up and getting to that point?
yeah. So when I first started, like, yeah, for sure, there's like MB2s where I couldn't get into it, and so in that case, like Dr. Sam said, you stop, temporize it, and give them ibuprofen and refer them and explain to them the situation. Like, hey, this is a more complex tooth. Like, I cleaned most of it, but I can't get into this canal. Like, we're gonna get you to the right person, and we're gonna make sure the root canal is really good, and just explain to them why you have to do that. And a lot of times they're understanding, and they like that you're looking out for their best health. So
Okay, awesome, perfect. Thank you again for that. One thing as we were pre-planning for this presentation that came up was patients love it when you take them out of pain, and how important that is. And just even removing the pulp releases pressure, and I mean the patient can feel that even if they're numb, just how much that is released. Would you agree to that? That how important that removing the
yeah,
patient from pain is?
if you do a pulpotomy, you definitely get them out of pain. So if you clean most of the pulp out of there, you already get them out of pain. But obviously, you want to make sure you clean all the canals. So if you can't clean all the canals, just close it up and refer them. But another thing is like a lot of these offices, they have multiple doctors there. So if there's someone a little bit more comfort or experience, you can bounce ideas off of them. So if you're newer at doing root canals, just don't be scared to ask for help. I mean, I know I'm willing to jump in and help like a newer doc or anything like that if they need it. So just don't be afraid to ask for help.
Great points. Excellent. Thank you for coming on and sharing. Thank you, Dr. Panya, as well,
Yeah.
for sharing your experience and going from, being afraid of it and then practicing and picking the right cases. I think is all really, really important in overcoming that fear and just doing it.
One thing I'd like to mention to piggyback on what Dennis had said, like you mentioned, patients are scared of the term root canal and the thing. One of the things I like to tell patients there is that, when they say, it's a big scary thing, I always tell them, like, hundreds of thousands of root canals are done every single day all across the country. 99.9999% of them are fine. It's that one little one that you hear all about. And I always relate it to the fact of the whole squeaky wheel situation. If you had a root canal done and it went fine, you're not going to go out and tell everybody I had a root canal done and it was the greatest experience of my life. Because a lot of times you don't want to have the embarrassment of telling somebody you had to get that done because they think, oh, I got a broken tooth, I wasn't taking care of my mouth or anything. But if you have a root canal and it went poorly, you're going to tell everybody and their grandmother what happened. So I always tell them that, and it usually relaxes them a lot. So just explaining to them that, and also just telling patients, hey, all a root canal is a filling for the inside part of the tooth. And that's basically what you're doing. You're cleaning out the decay on the outside. When you're filling the outside for a filling, you're putting a filling for the inside part of the tooth. And that helps, assuage their feels a little bit more as well.
That's a brilliant takeaway from this whole course. So yeah, thank you. Really, really appreciate that insight. Thank you both for coming on, presenting, and helping your colleagues out with that. Jeff, I'll turn it back to you if you have any other comments or thoughts.
No, I really don't. I just wanted to say thanks to Sam and Dennis and, Mish and you, Peter, and your team as well, for your input. The only comment I have is, do more endo. Your patients will appreciate it. I know that there's always times when you cannot do it for certain restorative reasons. Those are always appropriate, but, do more endo. Other than that, thank you guys for turning on. This was the largest turnout that we've had, for any of our CE courses. Thanks to Sarah for putting it together, and Dr. Levitt as well for contributions in the schedule. And I think everybody, when you see Sarah the next days, should say, hey, thanks. We got an unprecedented amount of emails setting this up to remind everybody that this was here. And we do have a couple more coming up. Sarah's going to let you guys know what those schedules are by sending out an email to everybody. I think we have one coming up that could be a longer one that we're trying to get Plan Mecca to give us a course on reading these cone beams that we have. Not only for implants, but as Sam mentioned, for doing endo. We have the technology, let's use it. So that'll be real important to time in. And if anybody has any questions, you have my number. I can get you Dr. Lamb's and Dr. Panja's. Pete, I know, would be a wealth of information. Carolyn too. Just reach out at any time. Phone call, text, email, anything works. So thank you guys for taking the time this evening. We had a schedule from 6 to 8, so finished a lot earlier. And enjoy the evening.
Thank you guys for participating. We've recorded this. We'll send over the recording and the CE certificates. Grateful for you making the time. Have a great night.
Thanks, Pete.
Thank you.
Thank you.
Thank you, everyone.
All right, bye, guys.
Bye-bye.
Bye. Bye now.